Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Usually, when we talk about a mechanical failure, we kind of expect a really straightforward mechanical fix.
Yeah, generally.
Like a strut snaps in a steel bridge, you replace the strut, or a pipe leaks under your sink, you patch the pipe. It's clean, it's definitive.
Well, sure, because you're dealing with isolated static systems there. But, I mean, the human body obviously doesn't work like a suspension bridge.
Exactly. And the moment you step into the world of pelvic floor reconstruction, that whole simple engineering paradigm just completely falls apart. So, welcome to the deep dive, everyone.
Glad to be here.
Today, we are talking directly to you, the surgeons, the doctors, and the clinical practitioners who are tuning in to really sharpen your understanding of pelvic mechanics. We're navigating the highly complex and, frankly, inherently murky clinical management of full-thickness rectal prolapse.
It's a tough one.
It really is. And just a quick reminder before we really get into the weeds here, this deep dive is for clinical reference and educational purposes only. So please, always follow your local guidelines in your own clinical practice.
Right, that is an important caveat, because rectal prolapse is, it's arguably one of the greatest anatomical and surgical puzzles in colorectal practice today. There is absolutely no one-size-fits-all flowchart for this.
Okay, let's unpack this then. I mean, we're dealing with a mechanical drop. An organ is literally, physically falling out of the body. Instinctually, the fix seems really obvious, right? Just push it back in and tie it down.
I mean, if you just push it back, the recurrence rate is essentially 100%.
Wow, 100%.
Yeah, because you aren't just dealing with a loose organ. Before we even discuss fixing the issue, we really have to precisely define what is actually falling apart in the first place. You know, we have to move past the basic textbook definitions.
Let's clarify exactly what is failing then. Because in the clinic, we hear a bunch of terms tossed around, procedentia, mucosal prolapse, internal intussusception. Mechanically speaking, what is the difference between the actual structural wall collapsing and, say, a really severe hemorrhoid situation?
Well, it comes down to the layers of the bowel involved. So with mucosal prolapse, which is actually often misdiagnosed as advanced internal hemorrhoids.
Oh, really?
Yeah, very often. In that case, you're only dealing with the innermost lining, right? The mucosa. It's just sliding down over the underlying muscle. So it's a surface level issue.
Okay, got it.
But classic rectal prolapse or procedentia, that's a full thickness, circumferential in the susception. The entire muscular tube of the rectum has completely inverted and is physically protruding right through the anal canal. The actual structural wall is on the outside.
Right. And when we look at the epidemiology from our sources, this heavily skews toward older women, specifically in their like 6th and 7th decades, though we do see it in men and somewhat surprisingly in kids under 3 years old.
Yeah, the pediatric cases are interesting, but totally different pathophysiology.
Right. But for that classic older female demographic, the risk factors are basically a cascade of pelvic stress. So chronic constipation, multiparity, pelvic floor weakness, and anatomically, a deep pouch of Douglas. I just want to pause right there.
Sure.
How does a deep pouch of Douglas actually cause a prolapse, mechanically speaking?
So think of the pelvic floor as a muscular hammock, right? It supports all your pelvic organs. Now, the pouch of Douglas is just the space between the rectum and the uterus. In a healthy pelvis, that space is relatively shallow.
Okay.
But a deep pouch of Douglas means that hammock has this really steep, unnatural dip in it. It physically creates a funnel. So every single time that patient strains to defecate, and keep in mind this is often over the course of decades due to chronic constipation.
Oh, decades of pressure.
Exactly. The intra-abdominal pressure forces the bowel straight down that anatomical funnel. It's guided right into the pelvic floor.
So decades of straining pushes the bowel down that funnel, and it just slowly stretches the ligaments until they basically give out.
Precisely. It's a manifestation of a global pelvic floor disorder. I mean, this doesn't just spontaneously drop out of the body on a random Tuesday.
Right.
It usually initiates maybe 6 to 8 centimeters above the anal verge as a circumferential internal intussusception. The rectum invaginates into itself, but it hasn't actually breached the outside yet.
Wow. Okay.
Yeah, so years of abnormal defecatory dynamics, a lack of fixation to the sacrum, and often a diastasis or, a separation of the levator ani muscles, all of that slowly perpetuates that internal descent until it finally externalizes.
It's like a telescope. Basically collapsing in on itself over the course of a decade.
That's a perfect way to visualize it.
And by the time they present in your clinic, they report a protruding mass, at first, maybe it just happens when they strain, but eventually it's just out permanently.
Yeah.
And they have mucus discharge, incontinence, and paradoxically, they might also report diarrhea alongside the obstructed defecation.
And that paradox is really key to understand. The quote-unquote diarrhea is often just overflow liquid stool. It's bypassing a hard, impacted mass of feces that the collapsed rectum can no longer physically expel.
Okay, so if this starts as a global pelvic floor disorder,
Right.
like a structural failure of the entire hammock, then treating it by just pushing the external prolapse back inside feels a bit like, well, it's like replacing a cracked windshield while completely ignoring the bent car frame.
That is exactly why non-operative measures alone fail to stop the progression of established full-thickness disease. If we connect this to the bigger picture, you can prescribe fiber, stool softeners, or even pelvic floor biofeedback.
Right.
And those are fantastic adjunctive therapies, but they are just treating the symptoms of the cracked windshield. They do not reconstruct the structural collapse of the frame. So to fix the frame, we really have to map the entire territory before we ever choose a surgical weapon.
Which brings us to mapping the pelvic floor. So clinical exam is obviously step one. You document the degree of prolapse. You have the patient physically strain. The source is mentioned using a commode examination in the clinic, which is incredibly useful for this.
Highly recommend it, yes.
You check sphincter tone, and crucially for women, you check for associated vaginal prolapse. Plus, you do a flexible sigmoidoscopy or colonoscopy just to rule out any malignancy.
Always.
But then, the guidelines strongly push for advanced imaging, like defecography or a dynamic MRI. And here's where it gets really interesting to me. If a patient is sitting in your clinic with an obvious, visually confirmed external prolapse hanging right there, why put them through a dynamic MRI? I mean, you can see the problem with your own eyes, right?
I get that often a lot, but it's because the external prolapse is often just the loudest symptom in the room. The MRI isn't there to confirm the rectal prolapse. We already know it's there. It's there to reveal the coexistent, silent structural issues.
Wait, really?
Right.
What exactly are we looking for on that scan that would actually change our surgical plan?
We are looking for the hidden co-conspirators. So, for example, an enterocele. That's when the small intestine herniates down into that deep pouch of Douglas we talked about earlier. Or maybe a massive rectocele where the front wall of the rectum bulges into the vagina.
Oh, wow.
Yeah. If you take a patient to the OR, you perform a rectopexy to pull the rectum up and fix it, but you completely ignore a massive enterocele. What do you think happens?
The small bowel just falls into the new empty space?
Exactly. The moment that patient stands up and strains, the small bowel slides straight down into that newly vacated space in the pelvis, and your surgery will fail. The structural why of the patient's specific pelvic floor defect completely dictates the how of our surgical intervention.
Okay, that makes total sense. So the imaging maps out all the specific architectural defects. Now you actually have to choose how to physically fix it. And as we established, conservative measures like fiber just aren't going to cut it for a full-thickness external prolapse.
Right. And when we cross into the surgical realm, we have three core aims. First, physically correct the prolapse. Second, improve, or at the very least preserve, the patient's continence. And third, avoid worsening their baseline constipation.
Which sounds pretty straightforward until you realize there is basically no single gold standard operation to achieve all three of those things at once.
Yeah.
We essentially divide the surgical algorithms into two camps, right? The abdominal approaches and the perineal approaches.
Yes. And the decision between those two is almost entirely dictated by the patient's physiological reserve.
Let's contextualize this with a scenario for our listeners. Say you have an 82-year-old female patient. She has severe COPD, an ejection fraction of maybe 25%, chronic kidney disease, and she presents with a massive, debilitating full-thickness prolapse. How does her frailty dictate the surgical camp we choose?
I mean, it dictates everything. The abdominal approach, going in through the belly to pull the bowel up and anchor it, is fundamentally a massive foundation repair on a house.
Right.
It absolutely offers lower recurrence rates and better functional outcomes, but it requires a laparotomy or prolonged pneumoperitoneum. If you subject an 82-year-old with a 25% ejection fraction to a prolonged abdominal surgery, her cardiopulmonary system simply cannot handle the physiological stress. The house will collapse during the foundation repair.
So for her, the abdominal camp is totally closed. You have to pivot to the perineal camp. You operate entirely from below. It's essentially like a localized patch job instead of a foundation repair.
Exactly. This raises an important question of balance, right? The perineal route trades a higher mathematical risk of the prolapse returning in the future for a much lower immediate physiological hit today. You are avoiding general anesthesia and abdominal entry basically just to keep her alive.
That is a fascinating trade-off. Let's assume for a moment, though, that we are dealing with a younger, fitter patient, say a 55-year-old who can easily handle the foundation repair. Let's explore the abdominal arsenal. We have several distinct techniques here. The traditional method is the abdominal rectopexy. You're mobilizing the rectum all the way down to the levator antemuscles, pulling it up out of the pelvis, and physically suturing it or using mesh to fix it to the sacrum.
Correct. You're restoring its anatomical position and relying on scar tissue to basically hold it there long term. Today, this is almost exclusively done laparoscopically or robotically, which is great because it gives you the functional results of open surgery, but drastically reduces the recovery time.
Nice.
And a quick clinical note on materials here. Historical techniques using posterior mesh made of non-absorbable sponges, like Evolon, have been totally abandoned.
Oh, really? Why is that?
The rates of infectious complications and pelvic erosion were just unacceptably high. We don't do that
Wow.
anymore.
Good to know.
Yeah.
But sometimes just pulling it up and anchoring it isn't enough, right?
Yeah.
We also have the resection rectopexy. This is where you pull the rectum and fix it. But you also cut out a large segment of the sigmoid colon and sew the two remaining ends together.
Right. That's specifically used for patients who have a very long, highly redundant rectosigmoid colon and suffer from severe intractable constipation. It directly addresses the anatomical redundancy that's causing the backup.
So what does this all mean? Mechanically, that makes total sense. If there's too much extra tubing causing a blockage, take out the extra tubing. So shouldn't we just resect the redundant bowel for everyone to cure the constipation for good?
It's an incredibly tempting reflex, I know, but we must heavily caution against it. The moment you resect bowel, you have to create a colorectal anastomosis. That's a surgical connection between the two ends, and that introduces a severe immediate risk, which is the anastomotic leak.
Right. What actually happens if that connection leaks deep down in the pelvis?
It is absolutely devastating. Stool leaks into the pelvic cavity, leading to rapid pelvic sepsis, abscess formation, and severe peritonitis. In a frail patient, or honestly even a fit patient who has baseline sphincter impairment, a pelvic leak can mean months in the ICU, a permanent stoma, or death.
Wow.
Furthermore, the intense inflammation from a leak can permanently destroy the function of whatever anal sphincters they had left. So the devastating cost of a leak far outweighs the benefit of marginally improved constipation. Patient selection for resection has to be absolutely critical.
So we really want to avoid resection unless it's strictly necessary. What is the alternative then for a patient who has a prolapse and obstructed defecation, but we don't want to risk a leak? This brings us to a newer, really highly nuanced tool, the laparoscopic ventral mesh rectopexy.
Yes, this technique has really gained a lot of traction recently, especially for internal intussusception and obstructed defecation. Instead of a massive posterior dissection around the back of the rectum, you do a very limited anterior mobilization. You're just dissecting the space between the rectum and the vagina. Then you place a strip of mesh on the front of the distal rectum and suspend it up to the sacral promontory.
Why does doing the dissection on the front rather than the back matter so much? Like, why is that the game changer?
It's all about nerve preservation. The autonomic nerve plexus, the sympathetic and parasympathetic nerves that control your pelvic function, they run posterior-laterally, so right along the back and the sides of the rectum. By entirely avoiding that deep posterior dissection, you completely spare those nerves.
And damaging those nerves is what leads to post-operative sexual dysfunction and bladder dysfunctions.
Exactly. Plus, mobilizing the entire rectum in the old traditional techniques basically denervated the bowel itself, which often severely worsened the patient's baseline constipation.
Oh, that makes sense.
Right. Ventral mesh avoids that denervation entirely, showing excellent functional results. Though I will add, as with any implanted foreign body, we are continuously monitoring the long-term data regarding mesh-related erosions.
Okay, so that's the abdominal side. We've basically mapped out the major foundation repairs. But let's go back to our 82-year-old COPD patient.
Okay.
The abdomen is an absolute no-go zone. We are pivoting to the perineal path.
Yeah.
I really want to understand the physical mechanics of this. If you are not opening the abdomen to pull the rectum back up, how on earth are you fixing a 5-inch external prolapse from the outside?
Well, you're basically either pleating it or you're amputating it.
Wow.
Yeah. The two mainstays here are the Delorme's procedure and the Altemeyer procedure.
Okay, let's take the Delorme's first. The texts call it a mucosal sleeve resection with application of the muscularis. Can you help me visualize that?
Sure. So imagine a room where the wallpaper is peeling off and the drywall underneath is just bulging outward. In a Delorme, you physically strip the mucosa, which is the wallpaper, off the entire length of the prolapsed segment of bowel that is literally hanging outside the body. You discard that mucosa entirely. Then you take stitches through the underlying muscle layer, the drywall, and you pull those stitches tight, basically pleating the muscle together like an accordion.
So you aren't actually removing the muscle itself, you're just bunching it all up.
Precisely. And as you tie those sutures, that bunched up muscle is pushed back inside the anal canal. It creates this thick, bulky muscle donut sitting right on top of the anal sphincters. This physically blocks the bowel from sliding down again, and that added bulk can actually help improve continence. It's really ideal for shorter, more distal prolapses.
But because you aren't fixing the lack of sacral fixation higher up in the pelvis, I imagine the recurrence rates are generally higher compared to an abdominal rectopexy.
That's the inherent trade-off, yeah.
And then there's the Altemeyer, the perineal rectosigmoidectomy. Conceptually, this procedure is intense. If the prolapse is too long for a Delorme, how does an Altemeyer actually work?
With the Altemeyer, you pull the prolapse fully out to its absolute maximum extent. Then you make a circumferential incision right through all the layers of the bowel wall just outside the anus.
So you're just cutting straight through it.
Straight through. You are now literally looking into the pelvic cavity from below. You continue to pull the redundant rectum and sigmoid colon out through that incision, pulling it entirely inside out until there's no more slack left.
That is wild.
It is. Then you ligate the blood vessels, physically amputate that massive redundant segment of bowel, and then hand sew the remaining healthy colon directly to the anal canal.
So you are doing a major bowel resection, pulling it completely out of the perineum and avoiding the abdomen entirely.
Yep.
You can even tighten up the pelvic floor muscles from below a levatorplasty before you sew the bowel back together just to improve continence. But again, mathematically, the recurrence rates for the Altemeyer are higher than if you went through the abdomen and anchored it to the spine. How do you, as a surgeon, manage a patient's expectations regarding those higher recurrence rates?
What's fascinating here is that the context of the patient completely changes the definition of clinical success. So for our 82-year-old with major cardiac comorbidities, a 25 or 30% chance of the prolapse returning in 5 years is a perfectly acceptable, even victorious trade-off.
Because the alternative is so much worse.
Exactly. The alternative is an abdominal surgery today that carries a massive immediate risk of mortality. You are buying her immediate physiological relief and quality of life right now without threatening her systemic stability.
It's pragmatic surgery at its finest. You treat the patient in front of you, not the textbook. Oh, and a quick historical footnote I saw in the sources. Older texts often mention the Tirschweier encirclement. They literally ran a silver wire around the anal sphincter, just under the skin, to basically tie the opening tight and physically keep the bowel from falling out.
Oh yeah, we have moved far, far beyond that. The rigid wire couldn't expand, so it tended to erode right through the delicate perianal tissue, causing horrific, uncontrollable infections. It is completely obsolete in modern practice.
Thankfully. So stepping back, whether we take the abdominal path or the perineal path, no matter which route is chosen, the surgeon and the patient must navigate the harsh reality of complications. There's no magic cure here.
None at all. I mean, systematic reviews show a lot of heterogeneity in the outcome data, but universal themes persist. Abdominal procedures absolutely offer lower recurrence and better functional outcomes, but at a higher cost of operative stress and surgical morbidity. Perineal procedures are far safer for the frail, but they carry a much higher risk of the prolapse simply returning.
Right, and the universal risks cross all techniques, right? Surgical bleeding, catastrophic anastomotic leaks if you resect, new or dramatically worsened constipation, and of course the recurrence itself. Plus, the specific anatomical risks we mentioned, like sexual or bladder dysfunction from autonomic nerve injury. It really highlights to you, the listener, that managing full-thickness rectal prolapse is far less about finding a perfect cure and basically entirely about high-stakes risk management and intense, honest patient counseling.
Precisely. The best surgery simply does not exist in a vacuum. It exists in the precise tailoring of the operative plan to the individual patient's exact anatomical defects, their physiological reserve, and their specific lifestyle goals. The surgical algorithm is a guide, but your clinical judgment in the exam room is what ultimately matters.
And that really brings us full circle. We started by talking about isolated mechanical failures, the broken strut, the leaky pipe, and how localized problems usually have clean solutions.
Yeah.
But we've seen today that the pelvis is a highly dynamic, interconnected suspension system.
Yeah.
Fixing the external prolapse without understanding the global pelvic floor failure is literally ignoring the bent frame of the car.
It demands total anatomical awareness from the surgeon.
Which leaves me with a final provocative thought for everyone to mull over. We noted that our contemporary understanding shows this entire cascade often begins as a 6 to 8 centimeter internal intussusception, years before it ever drops out as a full external prolapse.
Right.
If that is the mechanical genesis, will future surgical or endoscopic innovations allow us to intervene purely at that early internal stage? Could we physically stabilize that internal descent before the global pelvic floor hammock completely stretches and fails, potentially rendering these massive high-risk external prolapse surgeries entirely obsolete?
Yeah.
Just something to think about the next time you're evaluating a dynamic MRI.
It's a very compelling horizon for the entire field of pelvic reconstructive surgery. I'd love to see where we are in 10 years.
Indeed. Well, that wraps up our deep dive for today. To all the clinicians listening, if you found this breakdown valuable in sharpening your practice, do not forget to share it with at least one of your colleagues or friends to spread the word. The more we discuss these complex anatomical algorithms, the better our collective patient outcomes become. Also, make sure to check out our YouTube and other social media pages for more breakdowns of these surgical concepts. And definitely dig into our previous seasons and deep dives. We featured some very relevant clinical topics that tie directly into this pelvic floor discussion. Thanks for joining us today. Keep asking the hard questions, and we'll see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.